Welcome to part 2 of ABPA Guidelines series on lung talks. In this video, we will cover treatment strategies, monitoring, relapse management, and newer advances in management of ABPA. Treatment of ABPA is based on two major therapeutic approaches. First approach involves use of anti-inflammatory agents such as glucocorticoids or biological agents that target type 2 immune response, which help control exaggerated immune reactions seen in ABPA. Second approach involves antifungal therapy, which aims to reduce fungal colonization within airways. Main goals of treatment include relieving symptoms, improving asthma control, preventing asthma and ABPA exacerbations, preventing progression of bronchitis, and minimizing treatment-related adverse effects. The treatment principles for allergic bronchopulmonary mycosis are generally similar to those of ABPA, except that specific fungus involved guides choice of antifungal therapy. Treatment recommendations for ABPA. Guidelines recommend that asymptomatic patients with ABPA should not receive systemic therapy. In patients with serological ABPA, systemic treatment is recommended only when there is poor asthma control or recurrent exacerbations despite optimal asthma therapy. For treatment of acute ABPA, the recommended initial therapy includes oral prednisolone at a dose of 0.5 mg per kilogram for 2 to 4 weeks, followed by gradual tapering and completion of therapy over 4 months. Alternatively, oral itraconazole may be used for 4 months as initial therapy. Itraconazole is particularly recommended when systemic glucocorticoids are contraindicated. Additional treatment recommendations. Guidelines do not recommend the combination of itraconazole and glucocorticoids as first-line therapy for acute ABPA. However, short course of glucocorticoids lasting less than 2 weeks may sometimes be used initially along with itraconazole. High-dose inhaled corticosteroids should not be used as primary treatment for acute ABPA. Similarly, biological agents are not recommended as first-line therapy for treatment of acute ABPA. Other antifungal agents such as voriconazole, posaconazole, and isoconazole are not recommended as first-line agents for acute ABPA. These drugs may be considered when systemic glucocorticoids are contraindicated or when there is intolerance, failure, or resistance to itraconazole therapy. Treatment of ABPA includes three major categories of drugs: systemic glucocorticoids, antifungal agents, and biological agents. Systemic glucocorticoids are main anti-inflammatory therapy used to control immune response in ABPA. Prednisolone is commonly used, typically started at 0.5 mg per kilogram per day, followed by gradual tapering over several months. Other systemic steroids that may be used includes methylprednisolone and deflazacort. These drugs may cause adverse effects such as hyperglycemia, hypertension, weight gain, Cushingoid features, osteoporosis, opportunistic infections, psychiatric symptoms, cataract, gastritis, and suppression of hypothalamic pituitary adrenal axis. Antifungal therapy is used to reduce fungal colonization in airways. Most commonly used drug is itraconazole, given for several months, either as conventional capsule or as super bioavailable formulation. Other antifungal agents that may be used include voriconazole, posaconazole, and isoconazole. These medications may cause adverse effects such as gastrointestinal symptoms, liver toxicity, neurological symptoms, skin reactions, and QT interval prolongation. Therapeutic drug monitoring is recommended for some azole antifungals to optimize treatment and reduce toxicity. In selected cases, Nebulized amphotericin B, either deoxycholate or liposomal formulations, may also be used. In patients with difficult to treat disease, biological agents targeting type 2 inflammation may be considered. This includes omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab. These drugs are administered as subcutaneous injections at specified intervals and may cause adverse effects such as local injection reaction, headache, arthralgia, fatigue, and rarely anaphylaxis. Overall treatment of ABPA involves a combination of anti-inflammatory therapy, antifungal agents, and targeted biological therapies tailored according to disease severity, response to treatment, and patient tolerance. Treatment of ABPA exacerbation. Almost half of patients with allergic bronchopulmonary aspergillosis may experience exacerbation after stopping treatment. In patients with ABPA, worsening respiratory symptoms can occur due to several reasons, including asthma exacerbation, immunologically mediated exacerbation of ABPA, or infective exacerbation of bronchitis. These different causes can usually be distinguished by evaluating chest radiograph, serum total IgE, performing sputum bacterial cultures. In some patients, more than one cause of exacerbation may coexist. ABPA exacerbations are typically characterized by sustained clinical worsening for at least 2 weeks, appearance of new infiltrates on chest imaging, and increase in serum total IgE by at least 50% above baseline level measured during clinical stability. In clinical practice, acute ABPA exacerbations are treated in the same manner as newly diagnosed ABPA. Treatment options includes oral prednisolone or oral itraconazole. In patients with recurrent exacerbations, particularly those with frequent episodes over previous 1 to 2 years, combination of oral prednisolone and itraconazole may be used. Nebulized amphotericin B has shown poor efficiency in treatment of ABPA exacerbations. In cases that are refractory to oral glucocorticoids, pulse therapy with methylprednisolone may be considered. Current recommendations do not support use of biological agents or nebulized amphotericin B as treatment for acute ABPA exacerbations. Monitoring treatment response in ABPA. The treatment response in ABPA should ideally be assessed around 8 to 12 weeks after starting therapy. Monitoring is mainly based on clinical symptoms, total serum IgE levels, and chest radiographs. For symptom assessment, a semi-quantitative Likert scale can be used, ranging from no improvement or worsening to mild improvement of less than 25%, moderate 25 to 50, and significant improvement of more than 50%. In clinical trials, a visual analog scale may be used for symptom monitoring. A good treatment response in ABPA includes significant symptomatic improvement, usually defined as Likert scale or VAS improvement of 50% or more. There should be improvement in chest imaging findings along with at least 20% reduction in serum total IgE levels. Spirometry may be additionally used for monitoring with minimum clinically important difference for FEV1 being approximately 158 ml. Quality of life questionnaires are not recommended for routine clinical practice, although they may still be used in clinical trial settings. Laboratory markers and drug monitoring. Certain laboratory markers are not recommended for treatment response assessment in ABPA. This includes Aspergillus fumigatus specific IgE, Aspergillus specific IgG, peripheral blood eosinophil count, and IgE or IgG against recombinant antigens. Therapeutic drug monitoring is recommended when patients are receiving oral azole antifungals. Suggested monitoring intervals includes 2 weeks after initiation of therapy, again at 3 months, and during periods of clinical worsening. While using azole antifungals, liver function tests should be monitored carefully, and clinicians should remain alert for potential drug-to-drug interactions. Recommended minimum therapeutic trough levels are greater than 0.5 microgram per milliliter for itraconazole, greater than 1 microgram per milliliter for voriconazole, and greater than 1 microgram per milliliter for posaconazole. For patients receiving systemic glucocorticoids, monitoring should include plasma glucose, blood pressure, body weight, and mental status to detect adverse effects early. The stage-wise management of ABPA begins with patient who has newly diagnosed ABPA. Initial treatment consists of either glucocorticoids or oral itraconazole, typically administered for approximately 4 months. After treatment initiation, the patient should follow up evaluation after 8 to 12 weeks. Monitoring includes spirometry, serum total IgE levels, and chest radiographs. If patient shows clinical and radiological improvement, the condition is classified as treatment response. If this improvement is maintained and remains clinically stable for 6 months, the disease is considered to be in remission. However, if symptoms worsen, the patient is considered to have an exacerbation. For a first exacerbation, treatment is usually repeated with oral glucocorticoids or itraconazole for 4 months. In patients who experienced frequent exacerbations, treatment typically involves both oral glucocorticoids and itraconazole. If patient becomes treatment dependent, additional therapeutic options may be required. This may include oral azole antifungals, anti-type 2 biological agents, nebulized amphotericin B, or low-dose glucocorticoids. Remission may be achieved either after treatment with antifungal azoles or biological agents, or occasionally spontaneously after therapy. Management of treatment-dependent ABPA. Approximately 10 to 25% of patients with ABPA develop treatment-dependent disease. In these patients, itraconazole therapy may reduce requirement for oral glucocorticoids, decrease sputum eosinophil count, and reduce frequency of ABPA exacerbations. In addition, biological agents targeting type 2 inflammatory therapy may be useful. This includes monoclonal antibodies such as omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab. Among these agents, the greatest clinical experience in ABPA management is with omalizumab. So, for patients with treatment-dependent ABPA, the recommended treatment options include long-term itraconazole therapy, nebulized amphotericin B, or use of biological agents. Biological therapies may also be useful in controlling the underlying asthma that frequently coexists with ABPA. Continuous low-dose glucocorticoid therapy should generally be reserved as last option because of long-term potential adverse effects associated with chronic steroid use. During remission, when disease is stable, management of ABPA should focus on controlling underlying asthma and bronchiectasis. This may include inhaled corticosteroids, long-acting bronchodilators, nebulized saline, antibiotics when required, and other treatments according to existing respiratory guidelines. Patients should be monitored regularly with clinical evaluation, measurement of serum total IgE levels and lung function testing. Follow-up is generally recommended every 3 to 6 months during first year and every 6 to 12 months thereafter. How to maintain remission in ABPA? Remission in ABPA may be prolonged with the use of long-term antifungal therapy such as itraconazole, nebulized amphotericin B, or biological agents. These approaches may be particularly useful in patients with treatment-dependent disease. Current recommendations suggest that patients in remission should continue to be managed for their underlying asthma and bronchitis according to established guidelines. Patients receiving antifungal azoles or biological agents should also undergo periodic reassessment to determine whether these therapies needed to be continued. Management of advanced ABPA and extensive bronchitis. In these cases, supportive management strategies are important. Nebulized hypertonic saline may help reduce sputum viscosity and facilitate clearance of mucus plugs. Bronchodilators are usually administered before hypertonic saline to reduce bronchospasm. Patients with bronchitis and frequent infective exacerbation may benefit from nebulized antibiotics or long-term azithromycin therapy. In some patients, widespread bronchitis can eventually lead to complications such as chronic type 2 respiratory failure or pulmonary hypertension. Management in advanced disease may therefore include long-term oxygen therapy when indicated, appropriate vaccination against influenza and pneumococcus, consideration of lung transplantation in selected patients. Current recommendation advise following standard management guidelines used for other pulmonary diseases when considering long-term oxygen therapy, vaccination and lung transplantation. In last section, we will focus on treatment of ABPA in special situations and environmental control in ABPA. Management of ABPA during pregnancy focuses on optimizing asthma and ABPA control while minimizing harm to fetus. Most clinical trials of ABPA therapies have excluded pregnant women, and so recommendations are largely based on extrapolated data. Oral glucocorticoids are generally considered safe for use during pregnancy and may be used at same dose required for ABPA management. In contrast, oral itraconazole have been associated with increased risk of premature birth and abortions. Experience with biological agents during pregnancy is limited, and some studies suggest potential risks such as preterm delivery or fetal complications. Therefore, current recommendations suggest using systemic glucocorticoids for managing acute or treatment-dependent ABPA while avoiding azoles and biological agents. There are no randomized control trials specifically addressing treatment of ABPA in patients with cystic fibrosis. In clinical practice, glucocorticoids and azole antifungals are generally used as initial therapies. However, special considerations are required in these patients. Glucocorticoids may induce diabetes mellitus, which have significant consequences in individuals with cystic fibrosis. Itraconazole absorption may be erratic in these patients, making therapeutic drug monitoring important to ensure adequate treatment levels. Voriconazole may cause photosensitivity and should be used cautiously. So, current recommendation suggests managing cystic fibrosis associated ABPA using same treatment principle applied to ABPA in asthma, while carefully considering issues specific to cystic fibrosis. ABPA in children. Management of ABPA in children requires special attention to age-related factors. Systemic corticosteroids can lead to growth retardation, which is an important concern in pediatric patients. In addition, azole antifungals may have variable bioavailability in children due to age-related changes in drug metabolism involving cytochrome P450 enzymes. There are currently no randomized clinical trials evaluating ABPA specifically in children. However, systemic glucocorticoids or oral itraconazole are commonly used to treat acute ABPA in pediatric patients. Current recommendations suggest treating ABPA in children similar to adults while considering issues unique to pediatric patients. Environmental control in ABPA. Environmental control is an important aspect of managing ABPA. Aspergillus is a common mold present in soil, decaying vegetation, and indoor environments. Exposure may trigger exacerbations of ABPA. Therefore, patients are advised to avoid activities that involve exposure to large number of fungal spores. If such exposures cannot be avoided, use of surgical mask or preferably N95 respirators may help reduce inhalation of spores. Regular maintenance of heating, ventilation and air circulation system is important to prevent mold growth. Water leaks should be repaired promptly as damp environments promote fungal proliferation. Ensuring proper ventilation in bathroom, kitchen and other moist-prone areas can reduce mold growth. Regular cleaning using damp cloths help minimize accumulation and dispersion of spores in air. Indoor air quality monitoring may be useful in assessing fungal exposure in high-risk environments.